So again, I would like to thank everyone for being on today's VA CTO Club. It's already actually number 16, so it's been a while we'll be doing those. And today we're very grateful to have Dr. Barry Uretsky from Little Rock VA, who is one of the expert CTO interventionalists. He's done many cases, one of the first retrograde cases performed in the South, and has tremendous experience with this. So Barry, thanks again. Welcome to the CTO Club, and looking forward to good cases.
Great. Thanks, Manos. I have two cases that I thought would be of interest to the group in general. At least they were quite interesting to us. And I titled both of them difficult passages because that was the problem, difficult passages. So I'll present the first case, a 66-year-old man with worsening angina despite optimal medical therapy. 1 year earlier, he had a non-STEMI. It was found that he had a 90% obtuse marginal and a CTO of the right coronary. At that time, the obtuse marginal was stented, and a CAT 3 weeks before the procedure that I'll discuss showed that the obtuse marginal was patent, as were the other vessels, and he had simply a total CTO of the right. And I just should say parenthetically here that this is one of those examples where there's no obvious progression of disease, but yet symptoms get worse despite the fact that the anatomy seems angiographically fairly stable. We brought him in for a PCI of the right. So the angiographic summary, I'll show the angiogram, but in essence, he had a relatively short CTO, 20 millimeters or so. The proximal cap was fairly ambiguous. The distal cap was not at a bifurcation. There was a good landing zone. And we really couldn't see any good interventional collaterals. The JCTO score was 2, based on a blunt proximal cap, and as you'll see, a calcified segment where the CTO was. So our plan was to start with an antegrade intraluminal approach, which I should say that we do on almost every case that we do, even if we ultimately go retrograde. And then if that failed, which we anticipated it would, our plan was to go antegrade dissection reentry with the crossboss and the stingray.
Great, and actually, Barry, it's interesting you mentioned that because at the Summit 2, there was one similar case where the patient had a stable anatomy but developed symptoms lately. So it's kind of an interesting question why they develop symptoms later on.
Yeah, I mean, we've seen more than one case, and there's all these different reasons for it, but I think one possibility is that angiographically we don't have the level of resolution that we see small changes, and I think at some level when there are changes in when there's small changes that we can't see angiographically, it may actually impact on the patient's symptoms. But that's just my personal hypothesis, which may or may not be true.
No, absolutely. And again, you say maybe that's the case, or maybe some of the other vessels start developing subtotal disease, but because of the CTO, that may be more significant than we think.
Yeah, that's sort of what I was getting at. I agree with you. Okay, so here's the dual injection, and you'll see that the proximal cap is somewhat ambiguous. There's a branch that comes off of it right where the proximal cap is, and there's no beak that we could see. And so this was the concern we had, and we were thinking that if we were unable to puncture the cap in where we thought it was, we would do the scratch and go technique. Okay?
That's a great one, and I agree with you. It has this little branch there, it makes it a little harder to see.
Yeah. So this is what we did. So for the intraluminal approach, we used this. It just so happened that day that the Boston Scientific people were there, and they want to introduce this new catheter they have, the threader. So we used it for the first time, and we started with the Fielder XT, which really kept going into the side branch, and then the Pilot 200, which again primarily went into that side branch. So we decided to take out the threader and put a crossboss in, and we were going to puncture the proximal cap with the Confianza Pro 12, and then try to spin the Confianza Pro 12 probably in the subintimal plane. So we used the Confianza Pro 12, and we pushed it to where we thought that the vessel was, and we tried to advance the crossboss, but it only went a very short distance. We thought we were in the proximal cap, but not far. So at that point, we removed the Confianza Pro 12 and put a Fielder XT. We knuckled it and passed the calcified area. Okay?
So you did do a scratch and go after all, right? So you did do the scratch.
No, we didn't do scratch and go. We just went directly where we thought, because it was a short CTO, we thought this is where the direction is. So we just punctured with a Confianza Pro 12.
And what was your experience with the threader? We used it a few times as well, but what do you think?
Well, it may not have been obvious on the angiogram, but the proximal part of the right coronary, and you'll take a look there, had a little bend in it. And as the threader went around distally, it kind of bent the catheter, and the catheter has at the tip is a little bit like a fine cross, and it didn't really, it kind of crinkled up the catheter, and so we had to pull the catheter back in order to get the guide wire through it, once we were exchanging guide wires. So I thought, this was the first case. It may have been a difficult case, but the thickness of the distal part of the catheter was so thin, it was not very impressive. So that's the only experience I have with it.
Yeah, we'll give you a few cases. I agree with you. It gives you very good support. It's a little on the stiffer side, so when there's tortuosity, like the case you're showing now, it might have a little more hard time taking the turns compared to Corsair or Fine Cross, but otherwise I agree it's more of a supportive catheter.
And the other catheter, the other microcatheter that I learned about at the CTO Summit last week was this one from Vascular Solutions. And that looked like a good catheter too. Have you had any experience with that? We
don't have it yet. They got the Turnpike. So it looks pretty good. Yeah, I think they used it in actually an undergrad case, as you remember, in the summit. It looks fairly good and supportive. I mean, I haven't used it, but I think it's a good thing to have. To have, as you know, have these cases of going with retrograde with the wire, then the Corsair will not track. I think having more options to that, having the Corsair and having also the Turnpike, that could be something useful, I think.
Yeah. So here's our knuckled wire in the distal right, and I think in retrospect that the loop was a little on the far side, but we thought we would spin the crossboss down and then do stingray dissection reentry. The problem was we couldn't get the crossboss past the point where you see it there.
Okay, there's some calcium over there, so maybe you just couldn't track the calcium probably.
That was the problem. Okay, so the issue was this is where the difficult passage was, and so we thought that the next step would be to use a small balloon to try to make a little bit more space there. Okay, so we used a 1.2 by 10 balloon, but it arrived to that site but would not pass the site. It was just where we couldn't pass it, so we dilated proximal to it, and then tried to figure out the next step, which we decided might be put a guide liner down to that spot in a subintimal space. So that's
an interesting situation.
What?
It's an interesting situation. So it's a balloon uncrossable lesion essentially, but it's before you cross distally. So the challenge is you don't want to move too much the loop, I guess, the knuckle.
Yeah.
But you still have to get through somehow. And you're subintimally, right? So you're not true lumen. So even though you're subintimally, you still can't get the balloon through.
Right, that's right. And so is that what you would have done next, put the guide liner in?
Yeah, so sometimes, I mean, you can try the Corsair there or the Turnpike now. That's another option. Another option is to get a tornus going on. Now, some people might do the subintimal space rotablation, but I think that's probably on the aggressive side. I think it's very reasonable to have more support, get the guide liner down. That sounds perfectly fine.
Yeah, so what we did is we put the balloon up there, advanced the guide liner to that point over the balloon, and then tried to push the balloon through that spot, but it wouldn't go through. It still would not go through. So we were kind of stuck. So then what we did next was we took a fine cross, and fortunately the fine cross was able to traverse that site. Once we got the fine cross distally, we put a roto floppy wire in and decided to burr in the subintimal space with a small burr, 1.25 burr, at very high speed, 190K. This is the picture of that. I had never done this before. This is why it's interesting to me, because I had heard about it from several operators, but just had some anxiety about doing it. You know, just was a new thing, but it worked very well. It moved very easily. There was a little resistance at the place that we couldn't get through, but once we got through, this is sort of what you might call a polishing run. And then next slide, please. What happened is when we were working on this, the wire re-entered the distal right via an unintentional star technique during the knuckling earlier in the case. And actually, after that, all we did was balloon it a little bit. We're back in the vessel, and the next shot will show the final result.
Yeah, don't you love it when that happens? Doesn't happen very often, but when that happens, it's certainly a nice thing.
It was fantastic, you know, and it just sort of happened. I said, oh, it went in. I could see it go in. The vessel was not exactly fixed. A wire was not exactly fixed, and it went forward, and it looked great. So there it is.
And was it a pilot? What was the wire again that you had go through?
I think it was a pilot. The pilot 200 went through, but I can't quite remember that point. I'm being.
Sure.
It could have been the Fielder XT, but I do believe it was the pilot 200.
Yeah, I think it's a great case. I guess there was a small PL that might be nice to preserve, but I think overall that was a great case. And again, this is an interesting challenge when you cannot get through with the microcast of the balloon. Now, just curious, did you shorten the roto wire, or you just put it the way it is? You didn't do anything to it.
Say it again. What was the question?
So some people kind of shorten the roto wire. They're like, if it's a very short space, probably not in your case, they cut a little bit of the tip of the roto wire to have it so you can go further down and avoid the issues with clipping potentially the tip of the wire. But it looks to me like here you had a lot of space distally, right? So that was not an issue.
Yeah, no, we just kept the roto wire as it was, and then we after we did the rotablation, we used the fine cross again and used the regular wire to finish off the case.
Yeah, no, I think this looks an amazing case.
Yeah, it was a real interesting case, and as I said, I haven't done rotablation subintimally before, so I just had some unease about it, but we decided, okay, we're going to bite the bullet and do it, and it was really great. So, have you done this? Have you done rotablation subintimally?
I've done it a few times, but I will agree with you that even if you do it a few times, I think we should still feel uneasy about doing it.
Yeah.
And you obviously you want to make sure 100% your wire distally is really in the where it's supposed to be. It's subintimally dancing with the vessel, because obviously if this wire was not subintimally or was somewhere where it shouldn't be, that can be a major disaster, drilling a hole through there. So I think it's perfectly fine as long as you're 100% confident your wire is in a good distally is in a good position.
Right. So anyway, that's our successful case. So the next case I'm going to show was a difficult passage that wasn't quite as successful, you might say. Okay.
Sounds perfect. Let me bring on the next case.
Now, this is, we can always say that this unsuccessful cases were the work of my partner, and so this was work of my partner. Okay. But anyway, we work together. We all work together on these cases. So we have three of us that are doing this, and we work as two people for every case. So this was his case, and I was going to help him, and so I had a case in another room, and so he started the case. So this was a 47-year-old man with renal failure on hemodialysis, diabetic, hypertensive, previous bypass in about 15 years ago. In September of 2014, he had 100% LAD with a patent lima, 100% circumflex with a occluded SVG graft to the OM, and he had a patent right coronary artery. He had persistent severe angina despite optimal medical therapy. He had a moderate size reversible defect of the lateral wall. And at that time, in September 2014, there was an attempt to open the CTO, which was unsuccessful. Now, the angiographic summary is shown here. This CTO was really quite short, 10 millimeters. The proximal cap was clear. The distal cap was not out of bifurcation. The landing zone was fair, and there was one small epicardial collateral that we could see. That was really the only decent epicardial collateral there. There was only interventional collateral that we could see. And I'll try to show that, although the quality of the picture is poor. The CTO score was 2, and it was 2 because the proximal circumflex was extremely tortuous, really a tortuous vessel, and the patient had been tried before. Our attempt, as always, or almost always, was antegrade intraluminal, and then if that failed, which we didn't have too much expectation there, we thought we would try the epicardial collateral. Retrograde approach. So you can show the angiogram.
Okay, actually a couple of things. So I think, first of all, I love you do the JCTO score. You know, it's a great thing, I think, to do it ahead of time. Gives the lab an estimate of how difficult it's going to be. It may always perfect, but it's something great. And also, I love also that you started with the undergrade wires, even when retrograde option is there. You know, sometimes people get carried away and they say, look, retrograde should be the first option and go with safe. But I always agree. If you can try the undergrade for 5 minutes, if it works, saves you a lot of potential risk and makes things go faster.
Well, at any rate, this is I was in another room when this was all going on, but apparently there was a lot of access issues. The first was on the right. The operator said that there was severe scar tissue. He had to use an Amplatz extra stiff wire to make it track. And with the 7 French dilator, he said that in order to remove the dilator after he had put it in, he had to use a lot of force. So he ultimately got a 6 French sheath in place despite using a 7 French dilator. And then he took an access angiogram, which showed the sheath was in a decent place, and he exchanged it for a 45 cm 6 French sheath. He felt uneasy about trying to upsize it to an 8 French sheath. Now on the left, he said the access was smooth, but when he did an angiogram, and we always use a short sheath to start out with, and to see where we are. And when he did that, he was right at the bifurcation of the SFA and the profunda, so he chose not to upsize the sheath because he was concerned about trauma to the profunda. And so this case was done with 2 6 French guide catheters. I think that has some importance when you see what our problems were. Okay, so this is a dual angiogram, and you'll see that the circumflex, and you might point that out, Manos, is very tortuous, very, very tortuous. It goes up, it goes down, and it goes around. And if you look at around 7 o'clock, I mean, I can hardly see it, and I did the case, but at around 7 o'clock is a small epicardial collateral that connects to the distal.
Probably over there.
Yeah, right. You're pretty close there. That's the distal circumflex, and then if you go across, you can see right before where the PDA takes off is the origin of that epicardial collateral, and that's really the only that's the only collateral that we could find.
Yeah, it looks. It could be. I mean, it's not very big. It looks a little tortuous towards the apex. So not the best, but I guess not. I mean, there's bypass before previous bypass, so not bad. I guess if you have to do it, you can always try it. But again, you're right. The 6 French makes it a little more challenging.
Okay, so what we is this the next picture?
Yeah.
Okay, what we wanted to do was, if you look at the first obtuse marginal, there's a high-grade lesion in it. So we thought that we would fix that first. And so our plan was to fix that first and then try to open up the CTO of the circumflex itself.
Okay.
So we did stent the OM, and then we're now trying to get into the circumflex. The first wire was a standard wire, Pro Water Flex. It did take the circumflex bend, but we thought the tip of the wire, we weren't 100% sure, but we thought that it may either be subintimal or maybe in a little branch. It was just really hard to tell. You see it? You can see it though, right? What do you think? It's hard to tell, really, right?
Yeah, I agree with you. It's very hard to tell, and I mean, I guess IVUS might be a very useful thing here to just pinpoint where it is. But to me, it looks like maybe much more early on. Maybe the origin of the occlusion is much earlier.
I think so. And then, if you look at the way the Pro Water Flex is, it's sort of bending into the first obtuse marginal.
That's right. That's right.
And every time we tried to pass any kind of microcatheter, and we preferentially use the fine cross in this case, it would prolapse into the first obtuse marginal. So that
sure.
This is the first wire that we used where the fine cross prolapsed into the first obtuse marginal.
Sure, and then Barry, so did you do IVUS? You confirm that the entrance was up there? The entry point was up there?
No, we didn't do IVUS. We really were focusing a lot on trying to go around that bend. That was where we figured if we could go around the bend where the first OM was, it didn't really matter too much to me whether I was intraluminal or subintimal. I could have gone dissection reentry right after that. You know what I'm saying?
Absolutely.
So I just wanted to get around the bend. I couldn't do it with this particular wire and a fine cross.
And Barry, did you use any Venture by any chance? Venture might be a good one for this.
No. I mean, I think that's a very good point. We did not use a Venture, but it may have been a good tool in this case. So anyway, this just repeats what I just said. So we can go on to the next picture. So we did a Fielder XT. So this is now a Fielder XT, and again, I think we were somewhere subintimal, although I'm not sure where. But again, the fine cross wouldn't go around that bend. It kept prolapsing into the first OM. So that's what I just said. Next. So then we decided to go retrograde as a result of that. Now, before we go to the retrograde, do you have any other thoughts, Manos, other than the Venture, which I think is it's worth a try, I would have to say. And I think this is one of those circumstances where you're starting to think maybe an A French would have been a lot better now. Yeah, you know what I'm saying?
Yeah, absolutely. And I'm sorry, maybe I missed that, but did you do an IVUS to confirm that the entry point was there for the show?
Oh, I didn't do an IVUS. We didn't do an IVUS. But I don't think an IVUS would have gone around that bend either. I don't think anything would have gone on the bend. Yeah,
I was thinking earlier, like, I mean, looks like it's, but I was wondering in the previous picture, is it possible that the CTO actually starts a little earlier in the...
I do. I think it starts a lot. I think it does start earlier. I think we went too far. I completely agree with you. Yeah, I think it starts much earlier. And in fact, well, you'll see what follows, and that'll sort of give you an idea where it is.
But the other thing, we all know that actually doing the circ is harder than doing any other vessel. So the circs are notoriously difficult to open, no matter what we do. So it's tortuosity, and the collaterals are usually epicardial and tortuous, just like this one. So, I mean, it's the most challenging lesion we can do in CTOs.
I know, and I mean, we knew this going in. Is this the next picture?
Yeah, that's the next one.
Yeah, 1 sec. So anyway, we passed the Corsair through a 6 French JR4, and we were able to get the Scion wire into that collateral, which you can see, and it's important to just point out that the tip of the Corsair is right at the beginning of the collateral. Just at the tip of the Corsair is right where the collateral starts. So we were trying to spin the Corsair into the collateral. It just would not go. Okay?
Okay.
So what I tried to do was, and you'll see it here, I tried to just spin the wire into the circumflex, and it went pretty well. You can see that, right?
Yeah, it's moving up very nicely.
Okay, so I thought if I got some more purchase, I would be able to get the Corsair maybe into the vessel. But again, I just could not get it into the, in there. And then I tried also, I didn't make a note of it, but I tried also with a fine cross to get into the epicardial vessel, which again I couldn't do. The fine cross wouldn't go in either. And if you look at the next picture, where I think, not this picture, but the next one. Now this is where I think the CTO is actually, right there where the wire is bent.
Yeah.
That's right after the first obtuse marginal. So
That's right.
I was pretty close, but I just couldn't get any microcatheter into this very small epicardial vessel. And I know you're aware of it, Manos, but there are, in the setting of a cabbage, there's about 10 reported cases of localized hematoma or in the left atrial wall or in the pericardial space, which has compressed the left atrium and caused some catastrophic results. So even with the protection, you might say, of the previous bypass, I was a little uneasy about what you might consider the next step, which would be to maybe put a guide liner down and increase your support to try to get the Corsair or the fine cross into the epicardial vessel. And because of this, I just was uneasy about increasing my level of support. So you can go to the next one, because we're done the case. I stopped here, and the patient continues to have angina, and then I want to do it again. And the question that I'll ask you, and maybe anybody else on the line, is how much backup support is acceptable in this circumstance? Because I was really worried about traumatizing the epicardial collateral.
Well, actually, if I can go back one, so it would be interesting actually to inject undergrade here and see how far you are. But one option might be to just go undergrade now. You have the ambiguity is kind of resolved, right? And you can potentially just go undergrade and try to stick for where the wire is, just use it as a marker only.
Yeah,
so
yeah.
A possibility. Now, I think the reason you have the difficulty here is 6 friends to start with, so that's a problem. Then you have NJR, so support is not the greatest. And then it's a very long tortuous collateral, you're right, and it might cause a problem. And I know you published that case where you have the left atrial hematoma compressing the inflow, and that's obviously something not you don't want to have. Actually, I don't know if you saw that, but Bill Lombardi published the case, the similar thing, and he went to CT and did a tap under CT guidance. So
right.
A little heroic, I have to say, but it worked. And the patient avoided.
I heard about another case that Bill did. I don't know if it's published. I think it's not published, but he tried to he got the bronchoscopy people to intubate the esophagus and put a needle through the esophagus to the left atrium. You hear that?
Yeah, it sounds. I've heard about it. I haven't seen it. I don't think it's published. I've heard about it. Sounds interesting. Again, I'm not so sure. I think I would stick with the traditional method, but obviously if the patient is a high risk and it would be reduced sternotomy too, which may complicate things, especially in this case, then I think that's something potentially to try. It depends on your GI people too, if they have the comfort level to do something like this.
Yeah. No, it apparently wasn't that successful, but that's what they tried.
But I think in both cases,
we're going to go back. We're going to go back, we think, but the issue is how we should approach it next time.
Yeah, so I think, I guess the common denominator in both of your cases is that you're able to get the wire through somewhere, and then you have a hard time getting the microcatheter. So I guess the method is we need a better microcatheter in spite of, Corsair and maybe Turnpike, and Caravel is coming up as well. But it still looks there's room for having something more slippery that can go through those. Again, in this case, given what you've seen so far, and again, I may be wrong, but in my mind, I think the proximal cap is much more proximal in the left main, if I understand the picture correctly. You went to the collateral once, so that should be not as big of an issue, but one way to approach this time to go with 8 friends if you can on both sides. And or if everyone is on an issue, maybe go radial 8 friends, or put a seatless 7.5 friends radial, or anyway go big. And I would actually first do an undergrade attempt this time. You have a very good landing zone, and do an IVUS just to confirm you understand where the origin of the circ is, just to be 100% sure. If you do this and you see the origin of the circ is very, very close to where this wire could be, maybe just sticking with a venture might be a good initial approach. Again, try undergrade first. And then if it doesn't work, then do the same thing you did now, but with an 8 friends AL1 with maybe a guideliner and getting good support and doing the same thing. But I would still try undergrade first, given the complexities involved here.
Right. I think I've been practicing. I don't do it very often, and the last time I did it was a few years ago. But I've been practicing my coil skills also, because I think I think if the things go sour, they're going to go sour, and I think I'm going to have to stop the flow through the epicardial, and that may also compromise the distal. The patient may get ischemic, because that's really the only collateral that I can see to the distal circumflex.
So when you did the case, did he get ischemic?
He was a little restless. Yeah, he did get a little ischemic. But we were able to do the case. But he was not exactly. We were giving him a lot of narcotics because he was a little compromised by it. But we were able to proceed.
Okay. I think you're right. You may compromise the perfusion. Again, it's not a huge territory, but still, he might get hemodynamically unstable. But that's, I guess, another reason to try undergrade first before going retrograde here. Although I think if you tolerated the first one, you probably do okay on the second one. Now, the other option here, which we didn't discuss yet, will be about going through the occluded bypass graft to the OM. I don't know if there's any stump or anything you potentially get through that.
Yeah, I must say I don't recall, so I can't say for sure. But I think your point is well taken. As I recall, but I'm looking as we're talking. I'm looking at the previous one to see what they said about the stump. Because I didn't do that. That truly was my colleague.
Yeah, and I know. I mean, you're obviously the world expert on
Actually, I take it back. Well, let me see. That was the oldest one. No, he had that SVG graft was open actually at that time. And then it occluded. So I'll have to look this one over, because I'm not quite sure, Mano. So I'll have to look that part over again.
But listen, you have the most experience than anyone else on this. So if the vein graft is has a stump or it's localizable, that's another option. If everything else fails, go retrograde from the vein graft and either open the vein graft temporarily or go retrograde from the vein graft to open the native. But it looks like you have good options here, and the vessel seems to be big. I think once you get through that, it's going to be a large territory.
Yeah, I think so. Well, those have been very good suggestions, and I appreciate that. That we'll give you a follow-up when we try it the third time.
So, and radiation-wise, he was okay in terms of AK and all that. It's okay to go for a third time.
Yeah. We didn't use that much radiation, because all this actually. We used some fluoro to try to get around the bend, but other than that, the wire actually went easily into the epicardial, and we just were, it wasn't a long case. It just was a frustrating case, because I would have probably used a guideliner and tried to just give it some more support, but we were so burned by that case that was similar to this that I felt somewhat uneasy about testing the waters when it came to the pushing too hard on the epicardial collateral.
No, absolutely. And actually, so the other possibility there is I've seen some cases where Corsair does not go and Fine-Cross does, especially in the tortuous epicardials, which again, obviously, another option there as well. But
we did try a Fine-Cross.
You did, okay.
Yeah, and it wouldn't go, and that's a pretty small catheter. So the fact that it all got stuck on the same point, right at the origin of the vessel. Sure. And so I just didn't want to take the chance. But I may have been a little too timid, I'm not sure, but at least we have, you know, I always tell our fellows, he who fights and runs away gets to fight another day. So we'll try it on another day.
Well, I think it's a great message, actually, because, you know, yes, you can get extremely aggressive, but that's when the complications happen as well. So you convert a failed case to a complicated failed case. So that's not necessarily the best solution either. I mean, the patient here is fine, nothing happened, he can be tried again. If you push it too hard and you perfed, as you said, you might have had some major issues going on. So I'm completely on board with that and agree with you.
All right, great. All right, well, those are the two cases that I had to show today.
Great, Barry. Thank you so much. I think, you know, given the weather and everything else today, we're going to keep it short today and to the point, but these were two wonderful cases. Thank you very, very much for presenting them. And thanks to everyone else for being on the call. Again, we had a few people today given the weather. But again, I think the message here is we need a better microcatheter. So if anyone has any suggestions, that would be great for product development. I think the two things we need is microcatheters are better and also some sort of capsule device for retrograde, and third, good re-entry equipment. If we get those three things done, then CTOs will be much easier, but maybe too early about that.
Well, thank you for giving me the opportunity to present these. I enjoyed this a lot. Thank you.
It's been great. Thanks again, Barry, and thanks everyone for being on the call.
Okay.
Thank you.